Okay, well, I had to start the meeting all by myself today because Summer was not available, so it looks like it's working. And good morning, good afternoon, wherever you are. Welcome to RRR. And let's discuss. Anybody have anything they want to know about or talk about, either in any context? Please. I don't have anything. Well, I have one little thing, but I don't want to bore you with it. Nobody has any questions, has seen a case, has not seen a case, curious about something that would make it easier for us to talk. It's really hard doing RRR these days when I'm not physically part of the well, I'm kind of a part of the extracorporeal program at Davis. I got recalled back to Davis to see patients occasionally, but they haven't called me but once or twice. So, oh, and I did a great experiment a couple of weeks ago. I should have had that analyzed. I could have talked about that today.
Well, one thing, it's not really a burning question, but it's something we've been talking about here at North Carolina is we have gotten a few more hemoperfusion machines. So we've got the Purify and the Immunologic Revive machines. So we've been looking at using those for some more toxicities and just kind of debating between all of us here about when to reach for TPE versus hemoperfusion for NZ toxicities. And I know the data is not really out there yet, but just curious what your personal opinion on the matter was.
Yeah, maybe, and Jeff joined the meeting I see here. So, and I mentioned Jeff because he's chairing a hemoperfusion guidelines committee or a study group. And as you may know, that the IRIS has come out with guideline recommendations for intermittent hemodialysis and acute kidney injury. There's just about to, well, there's one on CRRT that's being formulated, and another one on hemoperfusion. And the hemoperfusion and the CRT are kind of about in the same stage of finalization. And so those will be out soon. And I think this would be a great place to start a discussion. I guess my biases have changed over the years, simply because our options have changed over the years. And it used to be, when we had these intoxications like the NSAIDs that had very high protein binding and very small distribution volume, that the only real thing that we had that was effective and reasonably safe was plasma exchange. But I think over the last 6 or 7 years, with the advent of much better sorbents that could be used for hemoperfusion or plasma absorption, I think in my mind that a lot of those indications have shifted more towards hemoperfusion. I made the statement when I was in our dialysis unit a week or so ago that because I think some people in our unit aren't necessarily completely versed in hemoperfusion, and maybe for an ibuprofen would lean towards plasma exchange, but I don't think for that kind of an intoxication that would be the platform that I would grab at the moment. I think you have better opportunity to get more complete decontamination with hemoperfusion. With plasma absorption, if you were really aggressive and did even as high as a 2 or 2.5 plasma volume exchange, you're getting maybe 70-80% of the removal. If it's just in the intravascular compartment, that may be sufficient. But if you had a really high intoxication, you remove 80%, there still might be a toxic level lurking. Or if it's a real severe intoxication, you would potentially have redistribution of that toxicant from a larger distribution pool. The plasma exchange wouldn't pick up because a plasma exchange is over in a couple of hours usually. And so you clean out the intravascular space and then that's it. So my inclination more recently is to lean towards hemoperfusion as probably a more reasonable option for a lot of these intoxications than plasma exchange. And again, plasma exchange is still fine. And for the longest time, it was all we had. But I think there's some a degree of evolution at this point. I see Dr. Foster just joined. I don't know whether he heard the conversation or not, but and then Jeff is also on the meeting, and so maybe they can give their perspectives on this as well, or anybody else that's on here that's dabbled with both plasma exchange and hemoperfusion for intoxications. Give your perspectives.
Yeah, I can comment just on our experience with some of the programs, some of the dialysis programs that we've worked with that have kind of made that shift. And Tufts would be the first one I was looking to see if maybe somebody from Tufts was on.
Jeff, Jeff. Well, he's from Cornell, so not as classy as Tufts by any means.
So the shift that we see, number one, would be particularly for NSAID toxicities. It's quite easy for carbon to remove, NSAIDs. They come off very quickly, very efficiently, and more completely, I think, than a typical TPE, unless you really do a large volume. So faster, but the experience has been that the feedback that I get is that faster, easier, and in a lot of cases less expensive because of the blood products. So that's one thing. And the other trend I would say that we've seen with the NSAID toxicities is higher proactivity to treat. So oftentimes we don't know what the dose was exactly, and avoid the wait and see is kind of the thinking. The trend, I would say, is we're going to be more proactive with our treatments. We're going to do it earlier because we know the effectiveness. There's a couple of abstracts that have been, well, I think two that'll be presented at Renal Week, but there's one study, which is an outcome study. It was based on about 40 patients with NSAID toxicities, and it was purely outcome related. There was no quantitative data. But then there was another study where we did get, I think there was over 20 patients that we had blood samples and lab analysis on for drug concentration, both of which showed a very good efficacy for it. So I think the trend for NSAID toxicities is pretty clear. There's a number of other toxicities that I think will follow that trend, but for now, just due to the volume of patients that have been treated, I think that the evidence is pretty clear, and you'll see that both at the meetings at IVEX at Renal Week, and also in publications here coming up this year.
I see Erica's also on the meeting, and Jethro, obviously, and Dan. I think I saw Dan on here. So I know some of you guys have had a reasonable experience, maybe even comparing plasma exchange to hemoperfusion. And any comments from those perspectives?
I mean, I would just, say somewhere in there, head to head, levels and rapidity of reduction of bloodstream levels is one part of it. But and I think Jeff kind of touched on it a little bit too, the practicality of, especially with standalone hemoperfusion units and pumps from a extracorporeal volume perspective, as well as the costs. As we shifted from needing to set up our Prismax and all the disposables that go into that, for the standalone hemoperfusion device, like the cost savings and the extracorporeal blood volume makes a huge difference from a practical sense as well, whether you're talking about plasma products or not also.
Yeah, if you're going to do a real high volume exchange to really remove a toxicant with plasma exchange, you're going to be out probably beyond 2 plasma volumes exchange. And if you have any kind of a reasonably sized animal, you're gonna need a lot of blood product, and that's a bit of the cost. I mean, that's a huge part of the cost. In fact, well, on Academy last week, I talked a little bit about the case examples of plasma exchange, and one of the cases I presented was, well, I forgot what the case was now, but the cost of plasma at some of these specialty hospitals was $20,000-$30,000 just for the plasma, and a lot of hospitals won't discount their plasma to get those patients in the hospital. But even if you do, you're talking about thousands of dollars of plasma for a 20-kilo dog that needs a 2.2 exchange treatment. So that's a factor. It's a big factor.
I know this seems like a funny factor too. We have just started delving into this in our hospital in Ohio, but we had a really massive sized dog, and we only had the Amicus TPE unit, and we now have a hemoperfusion unit. But the time it took us just to thaw all it was an ibuprofen, so we were trying to get them on the TPE device sooner. But just the time it took us to safely and carefully thaw all that plasma, because we don't have a rapid plasma warmer, like ate into our time that we would have wanted to get started on some of that. So that was just even a factor we hadn't even considered as well, versus putting them on like the purified pump or the hemoperfusion pumps where you can just get started right away.
See, Kate, what you started. All it takes is somebody to post a thought, and then we can have a big discussion. JD just posted what a lot of us are using. Plasma, rapid thawing devices cost quite a bit of money, and I think a lot of us have transitioned to very easily. You can go on Amazon and for $80 buy a Suve, and that's how we thaw our plasma in the dialysis unit, both at Davis and in San Diego. You can set it for 37 degrees and it's like a big water bath, and so for $80 you can have a plasma warmer it'll thaw all of that plasma in about 30.
Also double nicely as a line warmer when you're using the Prismax and the HF20 set.
Cedric, say that again. I think I cut you off a bit.
Oh, I was saying it also doubles very nicely as a line warmer for the HF20 on the Prismax.
Yeah. And with that, you run your lines through that same water bath that's powered by this $80 Suve, and you can titrate the temperature of the patient, simply by the temperature that you set the water to. Very, very useful. Other experiences with plasma exchange versus hemoperfusion for intoxications? Anybody? This is a good topic. I'm going to have to put my chat on here because I see there was a lot of chat today. I could find it. Well, don't stop talking now. Anybody have a case to present? Oh, people, you make me struggle here.
There, I'm digging for some of those abstracts. We had two that were presented to the American College of Medical Toxicology and accepted. And then the one that Zhuang did for IVEX last year, I'm just digging for those to see if I can uncover those, because those had some pretty good quantitative data in it.
Well, if you still dig for that, I'll start with something else. I usually try to have something up my sleeves. And this is something I was going to talk about at Renal Week, but since we need to fill some time here, I'll go ahead and share with you. In addition to plasma hemoperfusion, another option is, and let me just share my screen. It's going to be this one that I've been particularly attracted to and interested in is plasma absorption. And so plasma absorption is a therapy that you would do as an adjunct to, well, a couple of indications for it. You would do it as an adjunct to plasma exchange, and that's what I'll kind of give you an insight about now. Or something that, and carbon's not the only hemoperfusion product that is available or will be available on the market. There are lots of now that hemoperfusion is kind of coming back into a new realm in human medicine. There are a lot of devices that are designed to remove a specific substance, and some of those wouldn't necessarily be safe to do as hemoperfusion. The one that we've had some experience with a long time ago was a hemoperfusion or an absorptive column that was designed to remove soluble TNF receptors. And there were various reasons why you might want to remove these TNF receptors, because they get released in the circulation and then they bind TNF, and it really modulates the immune system. And so there was this device that would simply remove these floating receptors out of the circulation, but it was too toxic to the cells to do that. So you had to absorb plasma rather than whole blood, because you couldn't. The material that was the sorbent was too toxic for the cells in the blood. And there are other devices. I know there's a device in Europe that removes C-reactive protein, and there's a device that removes myasthenia antibodies. So there are lots of these devices that have been utilized, and there are more and more that are going to come to the surface in the next few years. And in some cases, then you may not be able to use the sorbent directly on whole blood because of its toxicity to the cellular components of blood. So in that case, you separate the cells from the plasma, and then you just run the plasma over the absorber. And where I got interested in this, and I'm showing this here, this graph, and this shows the typical elimination curve for a substance. If we look at the percent remaining in the circulation as a function of plasma volumes exchanged, so this would be the dose, we pretty much target this box right here. This is the sweet zone, and you can see this is an exponential curve. And to get out here to almost complete elimination of the substance, you need 5 or more plasma volumes to do that. Well, that's a huge amount of plasma that you would have to provide to do 5 plasma volumes of treatment, more than almost any blood bank would have on hand, and certainly the cost would be exorbitant. And so this is kind of the sweet zone, because the reduction up to this point is pretty linear. You get your best bang for your buck treating to about a 1.2 to maybe a 1.5 or 6 plasma volumes exchanged. And then you stop that treatment, let everything redistribute, come back the next day or a day or two later and do another treatment. And that's much more efficient than more efficient and more cost effective than trying to do all of this in one treatment. But these conventional doses don't completely remove a toxin or a pathogenic solute. They leave about 25 to 30% of it behind, and that still may be enough to promote the disease process. And even if you do daily schedules, that you may delay, because if you do daily schedules to get out to 5 plasma volumes of treatment, which you essentially need to do to treat a lot of these disorders, even with IMHA, we found in our studies that in order to really get a good survival, you need to do 4.5 to 5 plasma volumes. Well, that takes 4, 5, 6 days to do that, and so you really delay the time that you might be able to get those patients into some kind of remission. And again, here, if you're talking about a toxin, let's say you have a toxin that the toxic level is something like 50 or 60 ppm in the blood, and the patient comes in and they got a 5,000 or 6,000 ppm exposure. A 70% removal is not gonna make that patient detoxified completely, and they'll still be existing at a very, very large toxic dose. And so the thought is, this is where we get with plasma exchange, but this is where we want to be in order to treat the patient. And so the concept then, well, is there any way that we could extend the essentially the purification of the blood by some less expensive and more effective means, that during the initial treatment, if my cursor comes back here, during the initial treatment, you get the patient down to this level instead of at this level. Let me see if this thing's going to change now. Okay. And so what I've been toying with and playing with for the last 3 or 4 years is this concept. So you would do a plasma exchange, and that gets you pretty quickly down to 60 to maybe 75, 80% removal of your substance. And then you switch over and you put some kind of an absorptive device, whatever that device might be. The studies that we've mostly done have used carbon, but this could be a soluble TNF receptor. It could be anything else that would be specific for the substance you're trying to remove. And then you could do another 2, 3, 4, or 5 additional plasma volumes of treatment. In this case, though, you're treating the plasma, and so the patient's own plasma becomes the replacement solution. So now you separate the plasma from the cells. The plasma comes up, goes through your absorptive device into a small reservoir, and then you return that purified plasma back to the patient. And then the patient's own plasma serves as the replacement solution, and you don't have to have these additional stores to do another 4 plasma volumes of treatment, because the patient's own plasma is going to be purified by your sorbent and delivered back to the patient. And I've shown this many times, and maybe it's worth just going over this again for those of you who haven't seen it at Renal Week or haven't seen it at one of the other places where we've talked about this. Let me go back, because I think the first one is, yeah, so let's talk about how you would do this first on a centrifugal machine. It's really quite easy. And so here's the setup on our Optia. For those of you not familiar, this is the remove line. This line here is the line that so the blood comes in, it goes down into the centrifuge separates the plasma from the cells come up this line here into this reservoir, and then the plasma comes up this line, and then ordinarily would go up to the bag here. And then you would add your replacement solution that would come down through this line. So this line here that you can see with the clamp on it, that's this line, but you can see there's kind of there's a Y connector right here. And you can just add on to that Y connector, clamp off the remove up into the bag, which is shown here. And then all the plasma that comes out that line is going to come to this Y this Y connector, go through your sorbent, come out of the sorbent, and this line's a little small, so it's harder to see. And then we usually bring it up to a small reservoir because the remove pump and so the remove pump, which is this pump, and the replacement pump, which is this pump, don't necessarily work exactly at the same rate. And so you need a little bit of a volume buffer up here so that you don't start pushing air back to the patient. And then the purified plasma that comes out of your sorbent device goes up into this reservoir. It's been purified from the whatever toxin you're trying to, or substance you're trying to remove, and then that's delivered back to the patient through this line. And so that's how it's very easy to set that up on the Optia. You know, if you know you're going to do this, you just set this up in advance and you hook up all this plumbing. The device is already primed, and then simply all you have to do, let's go back one more step. So when you do your plasma exchange, this line is clamped and this line is clamped. And then when you do the plasma absorption, you clamp these two lines, and then the plasma gets purified and delivered back to the patient. On the Prismax, it's a little bit trickier. And we've fooled with a couple of different ways of doing this. And the first way that we did, and the problem is that you've got these scales on the Prismax or the Prismaflex that determine everything. And on these machines, and I probably need to show you on the next one, the effluent scale, which is going to be the product that comes out of this line, is going to go down into your waste bag or your effluent bag. And so you pull off X number of mils of plasma, and you have to deliver X number of mils of a replacement solution to exactly match the number of mils that you pulled off. So on the Prismax or the Prismaflex, the machine has to see that as the waste bag and the waste scale sees 3 mils of plasma, the remove bag has to demonstrate that it's lost 3 mils of solution. And we tried switching the bags and doing some other nonsense, and that didn't work very well. And so you can do this very easily on the Prismaflex or the Prismax, but you have to be a little bit more invasive. And so there are two things that you have to do. And so if we look at how the conventional plasma exchange is set up on this is the example of the Prismax, but the Prismaflex is the same. And I don't know, this is with the TPE 2000. I don't know whether the TPE 1000, which is the smaller filter, whether it has this connection here. This connection is to run the blood through the plasma warmer. But it's very nice. So the first thing you have to do is you have to disconnect this piece, and you're going to connect it to a stopcock. There are a couple of ways that you can do this. And so that the plasma, this would be the replacement solution now, is going to come out here, and it's going to go around like this so the blood, the blood with the extracted plasma is going to come out here, the concentrated cells go around here and then be delivered into the deaeration chamber. And then the plasma from your sorbent device is going to come in at this point, reconnect with the concentrated red cells, and then go back to the patient. So this is your purified plasma that's coming out here, and it's very easy to do this. You just instead of the plasma coming up through the normal replace line, which is this line down here, you just, with this three-way stopcock, you just run the purified plasma into the stopcock. It reunites with the blood and goes back to the patient. That's the easy part. The harder part is that this is the replace line here. And so everything that comes out of your bag, the replacement bag, ordinarily is delivered by this pump directly into the deaeration chamber. The blood comes out, goes into here, into the chamber, or in the normal fashion, and then the replacement solution joins that blood in the deaeration chamber. In this case, where we're doing the plasma absorption, we're going to reunite the blood and the plasma at this point that are going into here. And so every drop of fluid that comes out of, that gets pumped out of here, has to show up in the waste bag. So you have to make some modifications of that line, and there are two ways that we do this. And so here's that replace line coming in here to the deaeration chamber. One way is if you have a line, what are those things called? It's a line.
Crimper, is that what they are?
Yeah, something like that. It just seals, it's a line sealer. And again, you want to know this before you start the treatment. But if you decided at the last minute that you wanted to do plasma absorption, then you have to seal this line. But this whole system has to remain aseptic. And so if you use a line sealer, then you would just seal that line and cut it, and then you could swedge your stopcock right onto the end of that line. So this part of the system doesn't have to be sterile. But this part of the system does have to be sterile. And so another way of doing this would be, if you don't have a line sealer or don't want to do it this way, when you open up the set to put it on the machine, if you in advance, you know you're going to do plasma absorption at the end, you would aseptically, when you open that package up, everything in there is sterile. And so with sterile gloves and sterile scissors and everything aseptic, you would go in and cut that line. And then you would swedge on a sterile male-male connector, and you have a sterile stopcock here at this end, and then you hook that into your replace line. And so when you're doing your plasma exchange, you simply turn this to the off direction, and then all the plasma is going to come here through this direction into the deaeration chamber. And then when you want to do plasma absorption, you simply turn off that direction, and now all your plasma is going to come up here, go around this way into the waste bag. And so 5 mils of plasma comes up this line, 5 mils of plasma goes into the waste bag, and we can see that over here. So once you've transitioned to plasma absorption, whatever is on your waste bag, and that could be water. I mean, you could have anything in that waste bag at this point, because none of that's going to go to the patient. But everything that comes out of this bag is going to be delivered into this bag. The scales are going to be happy, and they'll be happy for hours and hours and hours and hours. And then you don't use any expensive materials to do this. You just use water, or if you wanted to hang a bag of saline, you could do that. But you could just fill that bag up with water. Then the fluid from this bag is going to be pumped out according to your prescription around the stopcock, and it's going to come around here and be delivered into the waste bag. And then the machine is entirely happy. And then you've got the other configuration where now the plasma is going to, maybe this is on the next slide. The plasma is going to come out of the plasma absorber, reconnect with the blood, and go into your deaeration chamber. Did I show that? Yeah, and so here's just a nice example. So we're removing this horrible green toxin, and you can see that here's our plasma separator. We've got green plasma coming out, being separated out from the blood, and that green plasma is going to be pumped by the effluent pump through the sorbent device, and now you got green coming in, and you've got absolutely purified plasma coming out of your sorbent device, and then that purified plasma is going to be reunited with the red cells and delivered directly into the deaeration chamber and go back to the patient. And then you could do this plasma absorption for another 2 or 3 or 4 plasma volumes of treatment. At the same time, we've got our replacement solution, and this is just yellow water, is going to come up the replacement line by being pumped by the replacement pump, comes to this line, which now ordinarily would go back to the patient, but now it's diverted, and that line goes directly back into the waste bag. So 3 mils of fluid comes out of this bag, 3 mils of fluid are delivered into this bag. This scale sees 3 mils were lost. This scale sees that 3 mils have been added, and the machine is entirely happy. Any questions about that? The only thing I'm going to caution you, you really have to recognize that you need to be aseptic about all of this. And so if you're planning on doing that, you have to set this up in advance of your treatment, because after this set comes out of the bag, it's not going to be sterile anymore. It's sterile when it's in the bag, and you can manipulate it and put all of this hardware on while it's in the bag, as long as you do it aseptically. Any questions about that?
Larry, I see the vet rescue device on there. So you guys have done this with your IMHA patients when you did TPE and did having that vet rescue device, which is also kind of known to remove cytokines and other things. Did you feel like you got a different response, or?
Well, this was just a simulation, Jay, and I'll get to IMHA here in just a second, and what we would do in that circumstance. And again, I'm not promoting any device here. When we set up and we set this up just really to take all these pictures, and so that was the device that our other devices didn't fit in this clamp. And so we had one of these and we just stuck it in the clamp. But this part is real. You can see this green coming in and this clear fluid coming out. And this was a demo that we had set up in preparation for the last renal week. But if you want me to pursue this, I've got some other slides to show you how I've pursued with this. But again, whatever the required sorbent material is, this is how you would put it in your system. On the Prismax or the Prismaflex platform in order to achieve plasma absorption. Otherwise, you really can't do plasma absorption very efficiently. But this works for hours and hours and hours. You could do 10 plasma volumes this way if you wanted to, and the scales would be absolutely happy.
Yeah, I love this concept. We obviously have an Amicus platform, so we were trying to figure out because we do have some vet rescue devices, and they do have a different complement of things they remove compared to the carbon ones. Just if it was worthwhile doing that.
You can do this on the Amicus too. We demonstrated that at the last renal week as well. We had the Amicus set up with plasma absorption. We also had the Optia set up with plasma absorption. It's a little bit different, and I don't know the Amicus well enough to, I helped them figure out how to set this up. And Amicus is probably interested in this because they're partnering with some other device companies to develop plasma absorption for that platform. And so it can be very readily and easily done on the Amicus platform as well as the Optia.
That's good to know. We can probably reach out to Amanda and see if we can work with them, because
Amanda was the one that did it at Renal Week. We set it up for her. We showed her. When I first told them I wanted when they were going to come to Renal Week, and I said, we really want to demonstrate this plasma absorption in addition to the other things that you're doing. And they said, oh, no, 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 no. And then when we finally got them there and did it, they said, wow, this is pretty cool. And then I know that they have some devices that they're interested in having attached to their machine. So I think this is a way of the future.
Good to know.
All right. Go ahead. Somebody else?
Yeah, maybe you're going to get into this. Hopefully so. If you're running the plasma through the adsorptive device, what is the target that is better removed as opposed to running the blood through the adsorptive device and foregoing the plasma extraction or exchange part of it?
Well, it all gets back to how much replacement solution do you want to provide with TPE? If we go back to the beginning here, Jethro, oh, come on, cursor. This is where we'd like our treatment to be. And let's say you're talking about an IMHA patient, and if you could get that patient treated with the equivalent of 4 plasma volumes exchanged on the first treatment, rather than 3 or 4 days later on the 3rd or 4th treatment, that would be a huge advantage in getting that patient stabilized on the first day. But if you want to do this, you've got to deliver, if you're going to do this by plasma exchange, you've got to deliver 5 plasma volumes of replacement solution. And that's going to be if you had if you had a plasma volume that was 1,000 mils, that's going to be 5,000 mils of replacement solution that you'd have to provide.
Yeah, no, that makes a lot of sense. Like that's perfect. I guess the question for me is if we're relying on the adsorptive device to purify the plasma that we've taken out so that we can reuse it and achieve that 4 to 5 plasma volume exchange, is that absorptive device removing the targets in an IMHA that we're trying to remove, and could we just do hemoabsorption instead of the plasma exchange part, if that's the purification part of the plasma?
Oh, yeah.
I love the plumbing. Like this
Yeah,
is
yeah. If so, this would be a situation like if you take an antibody mediated disease, the conventional hemoperfusion devices aren't going to remove those antibodies. So plasma exchange will remove them. Or if you had, let's take the case of a myeloma. I mean, a myasthenia gravis. There is a device out there that removes in humans that remove myasthenia gravis antibodies. And yeah, you would just do that as hemoperfusion. This is conceptually designed if you're doing plasma exchange. Well, let's talk about it in terms of the next slide here, because I think that shows it. So this was an IMHA patient, and we did plasma exchange on it in order to treat the antibodies. But this patient had a bilirubin of 60, and it was neurologically clinical for that bilirubin. And the goal was, could we do plasma exchange after the TPE that we treated conventionally to remove the antibodies? Could we add on plasma absorption to get rid of the bilirubin? Because we know there are devices that will remove the bilirubin. Both the carbon device and the vet rescue device will remove bilirubin. And so we did this on this dog, not to treat the IMHA, but to treat the hyperbilirubinemia. And so this is the plasma exchange piece. And so we did 1.5 plasma volumes of exchange here, and we only got a 38% reduction. Probably because this was probably an IgG. Well, this was bilirubin. This animal, I don't have a picture of this dog, but he was glowing. I mean, this dog was absolutely glowing. And so probably the 1.5 plasma volumes didn't treat that patient all the way down to where we would normally expect it to be, kind of down at this range, because there was tremendous intra-treatment redistribution of the bilirubin from extravascular compartments. And so, this only reduced to 38%. We put the plasma absorptive device on, and I put this in this because this sample got it broke in the freezer, so we weren't able to analyze this sample. But if I just projected it out to where it would have been, where we actually ended up doing 5.5 total plasma volumes of exchange on this, and from here to here we got another 66% reduction of the bilirubin, which on that treatment then gave us a 78% reduction in the single treatment. So there's something you just add on at the end of your plasma exchange. You could have stopped, hooked up your hemoperfusion system and done it that way, but you're already set up to do plasma absorption. What you want to remove is in the plasma, so you could just simply go forward and do plasma absorption instead of hemoperfusion in this case. Then there was a big rebound the next day from 10 up to 40. This was another plasma exchange, and then this one was shortened because the machine had a problem here, and so we didn't get quite we did this on the Prismax, and it timed out. And the Prismax gives you, I think, 8 hours, and then it says you're done, and there's no way you can go beyond that. And so we had some logistical things in here, and the machine had been on for 8 hours, and it got to this point, and it says, "All right, you're done." But this is an example of how you could extend a plasma exchange treatment doing plasma absorption to get more efficacy of solute removal in a single treatment than you would get if you just stopped with the plasma exchange. Does that make sense, Jethro?
Yeah, no, that it absolutely makes sense. Like the concept is pretty good. And I've got a grasp on it. I guess the question I have there, if the plasma that's going through the plasma absorption, we're seeing that, we're getting more plasma volume exchanges and the bilirubin's coming down. What about the antibody component that was removed? So, I mean, we've got contaminated plasma that we're running through the hemoperfusion device, pulling down bilirubin, giving back plasma that's got less bilirubin in it. What about the immune mediated components?
Well, this sorbent wasn't designed for removing antibodies. So bilirubin, I don't know how big bilirubin is. It's probably less than 100, a couple hundred Daltons. Where your antibody, if it's an IgG antibody, it's going to be 150,000 Daltons. And so this device that we used for this study or this treatment wasn't capable of removing antibodies. It might have removed other things that you would have wanted in the patient, cytokines or other things, but it wasn't designed to remove antibodies. And so that's why you needed to follow up with additional plasma exchange. But I'm getting to your point, all right?
Gotcha. Yeah, thank you.
And so maybe this explains it. In order to get absorption, you have to get your molecule exposed to the sorbent. And, it could be exposed to the sorbent on the surface, but that doesn't give you a lot of surface area. Where you really get the surface areas when you've got internal surface area that's been designed in the sorbent that will allow, you can't remove a big molecule with the sorbent if it can't get into to the sites of binding to do that. So if all of these channels here are places where whatever you're talking about could get absorbed, you can see these big chunks aren't going to get absorbed at this part of the surface area because they're just too big to get to that point. They might be absorbed on the surface, or they might be absorbed right here at the mouth of this channel, but they're not going to get down far enough to really embrace the surface area that's available in the interstices of the sorbent material. And so in the scanning EM, this is a scanning EM of carbon, and you can see you've got small pores where small molecules could distribute. Then you've got big pores where bigger molecules could be attached. One of the nice things about carbon is that this material can be formulated to do bigger and bigger kinds of molecules. I think a lot of you now are using probably with carbon, you're using Dublin. Maybe, I don't know, Jeff, if you've got Echo on the market yet, but you can see Dublin, the pore volume or the pore diameter for Dublin is, it goes from here to here. So you could maybe get some of these great big huge molecules right here, but you're not going to get them out to here. But if you made a carbon like this one, which I'm going to show you next, which has been called Felix, now the pore diameter is greatly expanded. So a molecule like an IgG, which I've tried to simulate here, really couldn't fit very far into Dublin, but it could fit nicely into Felix. And so we would have a lot of absorptive capacity in a sorbent like Felix that you wouldn't have in a sorbent like Echo. Where now you can see, if we've got a big IgG, maybe an IgM may fit into this pore, but it's not going to fit into that pore very well. Certainly not going to fit into these pores. And so we had Jeff was kind enough to build me a carbon, because I've been nagging him about this for a couple of years, to build me a carbon, and that was that Felix that had a pore distribution that was big enough to actually grab antibodies. And so the way we would do that study is you could do your plasma exchange here, and then turn off this piece, and then continue the plasma absorption with a device that would be designed to remove the material that you're trying to remove. In this case, it was antibodies, IgG antibodies, and we removed 19 grams of antibody or immunoglobulin with plasma exchange, and with I forgot how many this was. I don't remember how many volumes this was, but we removed another 19 grams of antibody of immunoglobulin in the sorbent. If we looked at, and so I'm looking at something that would, that we could use to measure that. And so we looked at canine distemper IgG titers, and we dropped that by from 1 to 4 down to 1 to 1. A two fold reduction in that IgG antibody with a 1.4 plasma volume of treatment. This looks at the inlet and the outlet concentration for immunoglobulin G, and you can see that out to 1.4 volumes of exchange, we still had absorption going on. This is probably looks like it might be getting a little bit saturated at this point. And then another, and that first device was very underpowered. It was just a little bit of carbon that they had. They sent it to me. We looked at it, and then I got some additional amounts of this material big enough for a real absorber. And we took that same plasma that was left over from that dog that we treated. So all of that was an ex vivo treatment from the waste plasma that we had on an IMHA patient. We put it in a Skippy here, and of the 18 grams of IgG that were in that reservoir, a little bit bigger device actually removed 11 grams of that, or got a 62% reduction ratio for immunoglobulin G with a little bit bigger and more capable device. And so if you put all of these together for an IMHA patient, and then we haven't measured anti-red blood cell antibody titers on that plasma, but we have that assay now. But just looking at changes in immunoglobulin G concentration, the plasma exchange reduced this much. And then by adding on the plasma absorption, we got an additional 60% absorption. So on that first treatment, we got an 80% reduction in the first treatment. And this probably represents some redistribution of antibody from the extravascular into the intravascular compartment. So 1.4 plasma volume treatment only gave us a 50% reduction. That's probably enough to allow you to transfuse that patient with incompatible blood. It probably changes the in-saline agglutination reaction a bit, but by adding the plasma absorption on, we got an 80% reduction, and that's usually what we would get potentially after 2 or 3 treatments. And so, let's see, well, I don't want to, this was left over from something else. But we've got it also configured where you could take this and you could put a couple of devices in here. So you could put your cytokine removal device. If you had one, you could put your antibody absorptive device, or whatever devices you want in here. You can run them in parallel to try to get greater blood purification at the at your first treatment where you're doing a plasma exchange. So this is just a concept I throw out, and I think there will be materials and devices that will be available in the future that will, or even some that are even currently available for cytokines. I mean, this would be if you wanted to really, you remove a certain amount of cytokines with your plasma exchange, and then you could extend that treatment with something that removes cytokines and remove a greater amount of them. The big problem with cytokines is that their generation rate is pretty fast. And so we'll have to play with these strategies to figure out, how they really work. One of the other advantages of extending the treatment with plasma absorption is it provides time to get redistribution of whatever you're trying to remove from the extravascular compartment into the intravascular compartment, so that you really end up with greater purification and greater clearance over the combined treatments. So that's my contribution for the day, since you guys wouldn't talk about a case.
Hey, Dr. C, I found an abstract. If you want me to share it, I sure can.
Stop sharing, maybe. If I can figure out where my controls are. Here they are.
I just sent a request.
Find my cursor, which is
Kind
floating.
of back to the first conversation we were having about toxicities and NSAIDs. So this is an ongoing study that we've been doing for several years. I hate to say how many, looking at NSAID toxicities treated with direct hemoperfusion, either direct hemoperfusion or in conjunction with a dialyzer. So a couple of points about this. We narrowed it to severe NSAID toxicities, and all of these patients had the samples taken, consistent protocol for sample collection. All the samples were sent in, analyzed, and we got quantitative data back. Because this goes back several years, I think there's a difference in the timing of initiation. I think that as time has gone on, again, we've been more proactive in getting the patients in, getting them hooked up, treating these patients sooner. Oftentimes not based on their clinical signs. Oftentimes it's just based on the reported incident. And so we're catching these patients sooner, which is a good thing. But we're also treating them longer. So the other thing we've certainly learned is that, while on the bench, when we do ex vivo tests and we look at clearance of ibuprofen or something on the bench, we get these really rapid decreases in concentration. I mean, 80% in 30 minutes or less. I mean, it's very, very fast. We're working with a single compartment model, right? We got a beaker of blood with ibuprofen in it, and the clearance is very fast. When we're dealing with a live patient and a very large intoxication, a very large exposure, it's a different ball of wax. So what we've thought, years ago, what we thought is, well, gosh, we can decrease the concentration in 30 minutes or in 90 minutes. And in a large overdose, even with a low volume distribution drug like ibuprofen, that's just not the case. The drugs behave differently at these very large overdoses. So my point is, in this, if we look at the results on this, so the median time from ingestion to treatment was 7 hours. The median duration of the treatment was 2 hours. So what I would suggest is that today our median time has decreased that we typically see, and the time of treatment has increased. So as that exposure goes up, we know that it just takes longer. But if you look at the clearance rates, for ibuprofen, we're looking at an average of about 54%, a range of 32 to 61% clearance. And
That's
then
not clearance, that's reduction.
I'm sorry, you're correct. Extraction, yeah, or reduction. We're not looking at extraction ratio either. We're looking at clearance. The extraction ratio would have been considerably higher across the device, but total body concentration. But if you look at that range, right, that range for ibuprofen is 400 mg per kg to 1800 mg per kg. And we often see these, we've seen them north of 3000 mg per kg. We've seen them north of 4000 mg per kg. And in these cases, it just takes a long time. We got to leave those patients, longer and slower is probably a better treatment strategy. But 72% for carprofen. So I think the average, if we look across all of the NSAIDs that are included in this study, the average was about 58% reduction. And I think that would be, if you're comparing, we don't have anything head to head with TPE, But all these patients did very well. We had 100% survival in this group of patients. The number of patients in this study is continually increasing because this is still an open study, but it gives you some data and some experience that we have. And I'm happy to try to answer any questions.
Thanks, Jim. See, Kate, what you started just by that simple little question. We wasted a whole hour just because you asked that simple little question at the beginning. All right, folks. Well, thanks for coming today. Who wants the last word? We often give it to Jethro, but I don't know. Does Jethro, do you have a last word?
Oh man, I feel like I've put too many words out there already, but go forth and much success in your blood purification efforts.
Well, those are good words. All right, folks. See you in a couple of weeks.